The first speaker, I am sure you're going to enjoy him. I just met him a few weeks ago when he was challenging somebody in a great way on a grand rounds that we had on global health. He's a senior lecturer, health services in the University of Washington School of Public Health and Community Medicine. He's also a faculty member and a senior lecturer in the School of, in the Department of Global Health, and he, as you see, is affiliated with a community-oriented public health practice program. He's an emergency physician in Seattle, and he had a medical degree from Stanford University, a Master of Public Health from the prestigious Johns Hopkins, and an AM from Harvard University. And I truly just went to him and I said, can you tell me what an AM is? And he says, that is a Harvard way to call an MA. They want to distinguish themselves, so they call MA. He spent more than 10 years in Nepal, working on various health programs and teaching in remote regions. His research projects include effective methods of disseminating determinants of population health to the general population in order to change societal structures to improve America's health. Equity Health website and the Population Health Forum, an organization launched that explores the overall health status of our society. A well-known speaker, author of several books, I leave you with Dr. Steve Besruchka.
Well, thank you very much, Dr. Pellegrini, and thank you all for coming tonight. And I'm going to ask a question that most of you will probably think is stupid. Do you want health or health care? Many of you would say, yes, of course, but aren't they really the same term? I used to think so. As a kid, I wanted to be a doctor, and then Sputnik was launched in 1957, which was over 50 years ago. And I got seduced into atomic energy and then into applied mathematics, and then found myself, as you saw, I was a graduate student at Harvard in the late 1960s. And I loved mathematics because, according to David Hilbert, it was a game played according to a set of simple rules with meaningless marks on paper. And maybe some of you can relate to that. But after a few years working towards a PhD, I decided I wanted to do something useful, and I returned to my calling to medicine, since I thought there was nothing more you could do that was so obviously beneficial to society. I've now been practicing medicine for about 35 years, and I continue to practice emergency medicine because I think it is something that benefits society. And as you heard, I've also worked overseas. But about 20 years ago, I began questioning how much good healthcare did for society. And there were many reasons, among them my own personal experiences and observations and looking at the data. So I no longer felt that medical care was that important in producing health, and I began to wonder what was, so I went to public health school. And there at Hopkins, they affirmed what I thought, namely medical care didn't do much, but I really wanted to know what did produce health in countries. And by 1995, I had developed my own perspective on that and began speaking to various groups. And I found that the concepts that I entertained 13 years ago have sort of stood the test of time. That is, I think they're about as true as anything that we think of in society today. However, that doesn't mean that they're accepted in public. Remember, Galileo said that the Earth went around the sun, a concept that was discovered 100 years before by Copernicus. And it took another 200 years before the church would accept that. So I wonder if what I'm going to talk to you tonight is something that you won't believe, but if we fast forward 200 years and ask, if we're still on the planet then, whether or not these concepts will have stood the test of time. And I think if we could do that, that you will find that they will. I used to ask, or I still do ask my students to summarize their basic ideas into one sentence. So if I ask that of my students, I should expect the same of myself. We die much younger than we should for living in the United States because of a disease called hood robinosis. So let's explore that leading killer in the world today. First, we have to give the obligatory black box warning. Okay? So this is really important for this. And what I want to say is, first, the United States is not that healthy compared to other countries. Our societal hierarchy is the key causal factor, and early life is when this operates for the most part, because early life is the most important factor in our health as adults. And finally, if we're going to do something, if we're going to get a prescription, we must focus on early life and on decreasing inequality. So these ideas will challenge where the responsibility for being healthy lies. And every couple of days, I do a bicycle ride in West Seattle, and I go by this particular sign, and it always reminds me that your health is your choice. I bet a lot of you believe that. I used to, but I can't find the evidence to suggest that it's true. So let's try and let's ask a question and say, how healthy is the United States? The world's richest, most powerful country. We spend over half of the world's health care bill. And if we rank countries by a reasonable measure of health, namely how long you can expect to live at today's mortality rates, that's called life expectancy, how many would give us the gold medal, the healthiest country in the world? How many would put us the top 5? 6 to 10? 1, 2, 11 to 15, 3. Oh, maybe a quarter of you. 16 to 20. 21 to 25. 26 to 30. Below 30. All of you with your hands up saying below 30 are correct if we use any other data source but the United Nations. If we go to I picked the best data source I can find. So if we go to the CIA World Rankings fact book on the web, you'll find we're 45th. So I could have kept going, but why is it that we're 45th, yet in the UN rankings we're only 30th? Well, the CIA and World Health Organization count tiny populations like Andorra sandwiched between France and Spain and Monaco and these other sort of entities that I don't think really rank as countries. So here we have it. We are 30th in what I call the Health Olympics. And since we're having an Olympic event in Beijing, why couldn't we have an event for health? It makes sense. Now, when you're confronted with data like this that challenges what you think is true, what's the first thing you do? Don't believe the data. Go to a variety of sources. I challenge my students to do that. And so you will not find any better numbers than these. The next thing to ask are the differences significant? 4.4 years separate us from the healthiest country in the world. Do you care if you spend another 4.4 years drooling in a nursing home? Probably not. So a little thought experiment. Suppose we did the calculations. These are 2005 calculations in the UN Human Development Report in November, published in November of last year. Suppose we did the calculations for 2001 with and without September 11th. How much difference would they make? 100th of a year, you wouldn't see any change. So 3,000 deaths, poof, made only 100th of a year difference in our life expectancy. And it's actually interesting because New York City did those calculations both with and without to see what would happen for just that place. All right, well, maybe that's where we've always been. Maybe we've always been just behind the pack, so to speak. Well, when I went to medical school in 1970, we were 12th. When I went to public health school in 1992, we were 22nd. Last year, we were one notch ahead. So what's been happening is while our health has been improving, it's not improving as quickly as it has been in all the other rich countries and a few poor ones as well. Why? How many have been to a healthier country and can speculate on why? Well, I used to think individual behaviors were the critical thing in producing health. After all, it was your choice. And so out of all the countries on this list, think of an odious habit such as smoking. Out of all the countries on this list, which country has the lowest percentage of men smoking? A hint, it's not Japan. It happens to be United States. Which country on this list has the highest percentage of men smoking? Everybody agrees, Japan. So imagine that. Is that the reason Japan's so healthy? They all smoke so much? They smoke twice as much as we do among men. It's not true for women. But if we looked at male life expectancy, we'd see the same results. Once I confronted these data, I could no longer fall back on the kinds of things I had been indoctrinated to think in medical school. Because every profession, every thing that you sort of do has some ideas and that you're sort of brought in to believe without having to question. So what about Japan? Where was Japan when, in say 1950? In 1950, in my medical school notes, I read that we had the lowest maternal mortality ratio of all countries. These days, we're about the same as we are. There are about 30 countries ahead of us. That is deaths related to pregnancy. So 50 years ago, where was Japan? Well, it was less, it would be off the chart. It would be way off around 45th or 50th. We don't have good data. But by 1978, Japan became the healthiest country. And so if you look at trends for life expectancy, these are trends from 1960 to 1983, what you see is countries are improving. This Japan, United States, Norway, UK, and the United States. We're at the bottom, but we're doing better. But look at what Japan was doing. And at some point in the discussion, if you're interested, I can present the information that we gave Japan the medicine it needed to become the healthiest country in the world. We can take justifiable pride in that. Well, I was talking about life expectancy, average number of years lived. You could also look at other measures of health, infant mortality, what percentage or proportion of infants die in their first year of life. And of course, we don't do any better there than we do for life expectancy. And we could take a variety of other mortality measures and ask, how well are we doing? And unfortunately, it doesn't look good for us. What do medical students know about this? Well, a survey done in 2002 found that almost 30% of first-year medical students thought the United States had the longest life expectancy. And by fourth year, the proportion had increased to 35% almost. Imagine that. We've taught these medical students how to think. Now, for infant mortality, I'm pleased to report that the percentage thinking we had the lowest infant mortality rate was 40% in year 1 and dropped to 30% by year 4. But what are we teaching medical students if they come away thinking we're the healthiest country in the world? We're not doing their patients or them a service. This is a graph of infant mortality rates in 1979, with the dark black bars being the 1979 number and the lighter gray bars being the 2003 number. And you can see that the United States is at the top. We weren't. We didn't have the worst outcomes in 1979, but by 2003 we did. So something has been happening in this country over the last 30 or 40 years that has resulted in a relative health decline if the measure is comparing ourselves with other countries. And that's what the Olympics are all about. Well, those are all mortality measures. How about other measures? These are teen birth rates. These are countries' teen birth rates, women aged 15 to 19. And you see that we have a 20 times the teen birth rate of some of the lowest teen birth rate countries in the world. This should be a cause for alarm. What do men do? Well, men kill in this country, right? This is youth homicide rate, the number of murders committed by boys aged 10 to 29. As a proportion per 100,000. And you can see we're way ahead of all the other countries. And I would offer that it's how young people take out the stress in our society today. Girls have babies and boys kill. Nothing I've said so far you will not find in major publications financed by our federal government. The Institute of Medicine's The Future of the Public's Health in the 21st Century writes in this publication on page 19, for years, life expectancies of both men and women have lagged behind those of their counterparts in most other industrialized nations. For years suggest it wasn't always the case, and that's in fact true. So, to try and distill this into some ideas of population health, the first thing to recognize is that you are probably will outlive your parents. Hopefully your children will outlive you. That is, health keeps on improving. But these health improvements are not shared equally. How can we look at that? This is a map of United States counties with female life expectancy for 1990, with the red being the lowest, around 70 years, and the dark purple being the highest, around 90 years. That's a 20-year gap in life expectancy. And where's all the good health? Well, the Midwest. Where's all the poor health? Southeast. Notice New Orleans and Louisiana. Katrina wasn't an accident. What are some areas such as this red right next to the purple? Pine Ridge Indian Reservation in South Dakota, the worst health outcomes in the United States. So we're looking at huge health disparities within our country, richest, most powerful country in world history, with our leaders tell us the best healthcare system in the world. Let's look closer to home. British Columbia. How many have been to Canada? Okay. How many have been to BC? Is it obvious that it's healthier than we are? I ask you to ponder that. This is life expectancy trends in British Columbia compared to Idaho and Washington from 1980 to 2000. The gap was only about a year back in 1980, but it's over 2.5 years now. So Canada's doing something a lot better than we are, and I think we need to take notice. And if you look at a map of life expectancies in the same way that we looked at the USA map, what you find is the 49th parallel, just 100 miles north of here, is a huge health divide. Hell of a lot healthier north of that, and we're paying the price by pushing up daisies a lot sooner than we should down here. So why? If you remember one thing, if you remember only one thing, it is that poorer people have poorer health. And the amount that poorer people's health is worse depends on the gap between the rich and the poor. Poorer people have poorer health. How can we study that? Well, it first came to medical attention in 1992 in the British Medical Journal when a paper was published looking at income distribution of 11 countries and their life expectancy. And these were data for 1981. And you'll see that back then, Germany was still less healthy than the United States. That, of course, is no longer the case. But there was a very good relationship. And don't worry about the numbers on the axes other than the vertical axis is life expectancy. All of the studies use different measures of income inequality. And so I'll try and point out from the arrows on the graph which is more equal and which is less equal. So this really caught people's attention, and we could then use this kind of experiment to consider other populations. Now, the United States is 50 states. Suppose we considered each state as if it was a country and did the same calculations for income distribution and, in this case, mortality rate. The vertical axis is mortality rate, so lower numbers are better. And what you see is in this scatter plot that Louisiana, Mississippi, Alabama, Kentucky, West Virginia, the states in the upper left, have about a 50% greater mortality rate than Utah, Iowa, Minnesota, North Dakota, the Midwestern states that you saw on the map. Again, higher numbers on the x-axis means more income equality. Now remember, Canada's so much healthier than we are. Canada's 10 provinces. Suppose we threw the 10 provinces into this graph. And if the relationship held true with that, where would we expect the 10 provinces to cluster? I hope some of you are saying lower right, because that's in fact true. And so what this shows is if we throw the 10 provinces into the US states graph, they all cluster at this small gap between the rich and the poor, much lower mortality. And what this figure also demonstrates is that just for living in Canada, your mortality in working-age people is about 40 to 50% lower than being down here. That's a big difference. Well, what about teen birth rates? Rachel Golden, she was an epidemiology PhD student here, found an association between teen birth rates in the United States and the income gap in counties. And the same relationship has been demonstrated among countries. So you can see the United States way in the upper right has the biggest gap between the rich and the poor and the biggest teen birth rate. And notice how there's a gradient there. That is, the bigger the gap between the rich and the poor, the more likely are that young women are going to have babies. The same thing is true for youth homicides. This is a graph of homicide rates on the vertical axis and teen birth rates on the horizontal axis for U.S. states. And so states that have high teen birth rates also have high youth homicide rates. Okay, what does the Institute of Medicine say? It's pretty clear. More egalitarian societies, i.e. those with a less steep differential between the richest and the poorest, have better average health. Seems pretty clear. Early life is the most critical period for adult health. Now, that's not so clear. I will show you some statements from the Institute of Medicine, but it's very hard to study early life, and so we have to look at a variety of different models and experiments. But Clyde Hertzman, Irv Emanuel, who's in our epidemiology department here, has studied the importance of the period in the womb, and he says life begins at conception and ends at birth, since most of the things, most of our health as adults are already determined there. And he's also found an intergenerational effect, namely, a lot of our health depends on conditions that our mother faced in her mother's womb. And so to paraphrase Wordsworth, the daughter is the mother of the woman. So there are factors that are latent, namely, if they're present early in life, they're going to affect your health no matter what. There are pathway factors, whether you went to preschool or whether you went to whether you didn't go to school at all or things like that. And there are cumulative factors, how many cigarettes you smoked or how many times you got dead drunk. And the societal factors are really critically important in that. Now, to separate birth, before birth and after birth, fetal programming is the term given to all the things that happen in the fetus that result in adult health. And we now know many of the biochemical mechanisms involved in these, and we have a lot of studies, and the evidence is extremely strong. And you will also find this in major publications. This is a Newsweek article in September 1999 that talks about maternal stress having poor fetal outcomes, and the fetus is also stressed. And who do you think gets more stressed, richer people or poorer people? Poorer moms have more stress, and you see this in biochemical parameters and physiological parameters that you measure in both the fetus and in the mother. But we live in a womb with a view. That is, the fetus sees life outside and sees the conditions, sees relative poverty. And if you read the papers recently, they're talking about poverty being a poison for infants. American Association for the Advancement of Science meetings in Boston had some papers on this presented on Saturday. What happens after birth is called biological embedding, just a different term. And what happens basically is there's a lot of sculpting going on in the brain, and neuronal connections are made and remade, and rates of growth are really, really important, and a lot of our diseases are programmed in that early period of life. A critically important part of that is what John Bowlby, a British psychiatrist who studied orphans after World War II, called attachment. If you think about it, we are the only primate species with whites in our eyes. Anytime you wander, go to Woodland Park Zoo and look at some of your cousins and see whether you see whites in their eyes or brown. Why do we have whites in our eyes as the only primate? Well, I used to think it was for contact among fellow adults. If I was standing up here wearing sunglasses, what would you think of the material I was presenting? Probably wouldn't want to believe me so much. But the most critical time Bowlby found was soon after birth. Babies don't have good vision. They can see contrast. They can see black and white. And what's the most important black and white they have to see? The iris and the sclera. That is, they have to see the whites and the pupil. There's another important thing I learned that babies have to see soon after birth, and that is the pigmented areola on the breast, so they know where to go. So those things are critical, but secure attachment, what Bowlby found was that if an infant sees a single pair of eyes and sees them over and over again, then there's a relationship that occurs, and the infant is secure to explore its surroundings and then come back and see that those eyes are still there. So creating conditions that allow the same pair of eyes to be there throughout much of the first year of life is a critically important thing for our health as adults. And eyes are really critically important. If I just ask you to think of the Afghani woman's face on the cover of National Geographic, published over 25 years ago by Steve McCurry, you all know what eyes I'm talking about. So this kind of communication is very important, and you have to have the conditions for a mother or a mother substitute to bond with the baby in that way. United States, Swaziland, Lesotho, and Papua New Guinea are the only 4 countries in the world without a paid maternity leave policy. United States, Swaziland, Lesotho, and Papua New Guinea, the only 4 countries in the world without a paid maternity leave policy. And if you doubt me, use your search engine and you'll find it for any other country. It's too expensive for us. What do some of the healthier countries do? Well, take Sweden, for example. It is mandatory to have a year's paternity leave at full pay. You can't get out of it. It's tough, I know. If you want a second year, it's only 80% pay. Okay, tough. And then if you decide to put your child in daycare and go back to work in your 3rd year, daycare is free in Sweden, and the requirement to work in a Swedish daycare center is you have to have a master's degree in play. Because after all, what's daycare all about? It's socializing the infant, and you need experts for that. And everything I've said you'll find in, again, Institute of Medicine publications, especially this one, From Neurons to Neighborhoods. Of all aspects of a children's early environment, the family's socioeconomic status is most powerfully associated with children's cognitive skills and so on. And that socioeconomic status in early years is more important than socioeconomic status in later years. So this is the consensus of the experts. So I would suggest a hierarchy is the upstream problem, and it's really present in most of the social issues that we face in the United States. Again, the concluding 2 sentences of the major book on preventive medicine written by the British epidemiologist Geoffrey Rose says, the primary determinants of disease are mainly economic and social, and therefore the remedies must also be economic and social. Medicine and politics cannot and should not be kept apart. I leave you with that. Well, what did we used to think of? This is the front page of a New York Times, 1942, April 28th. What's the lead headline? $25,000 income limit asked by president. Could you believe that a Democratic president proposed a maximum wage in this country? Wasn't that long ago. If you don't believe me, go to Suzzalo and dig this out as I did. A Republican president proposed a guaranteed income in 1969. Richard Nixon said that if you have income, we'll tax it, and if you don't have income, we'll give you income in his family assistance plan. For the first time in America's history, we established a floor under the income of every American family with children, said Nixon. Editorials were 95% in favor at that time. That wasn't that long ago. Some of you can remember that. The bill passed the House, it languished in the Senate, Nixon got embroiled in Watergate, and it was history. Why did that happen? You know, we're not anywhere there today. All this sounds like science fiction. Well, the interesting thing was that the richest 1% of the country had seen their wealth decline, so that by the mid-1970s, instead of having almost half of the wealth in this country, the richest 1% had less than a quarter. Imagine that. The richest and powerful people in the world have always only wanted one thing, and that's everything. And imagine what happened when you saw your wealth decline, so it was only 25 times what the rest of what your percentage share ought to be. So what did they do? Well, we're living it today. We've decided to give everything back to the rich so we can have less so the rich can have more, and we glorify this. If you look at income gains in the 1960s and 70s, it was the poorest fifth that got as much as the richest fifth. But Business Week saw the problem. And so in 1974, they wrote, "It will be a hard pill for many Americans to swallow, the idea of doing less so that big business can have more. Nothing that this nation or any other nation has done in modern economic history compares in difficulty with the selling job that must now be done to make people accept the new reality." And accept it we have. Because after that, tax rates went down. These are the highest marginal tax rates. They used to be 91% back in the 1950s. That is, if you made $1 million and you earned another dollar, 91 cents of that went in taxes. These days, it's about 35%. The lowest line there is the lowest marginal tax rate, and you can see that it hasn't changed much. So all that says is that the rest of us are paying a disproportionate share of the taxes. And household income has actually declined in 4/5 of the United States since then. David K. Johnson, some of you may read in the New York Times, he just published a book. He wrote a book called Free Lunch, about how the richest Americans are enriching themselves at our expense. And he points out that the bottom 270 million, the bottom 90% of this country, he calls the vast majority, have actually seen their income shares decline since from 1980 to 2005. And of course, the richest 1% are laughing all the way to their offshore banks, and the richest 0.01%, I mean, they're really extragalactic. And how did they do this? This is the richest 1%, richest 1,000th of the country, richest 0.1%'s income share on the bottom until it crosses in around 1980, in the 1980s. And this is the highest marginal tax rate. So as the tax rates went down, the richest share went up. Go figure. Thomas Pynchon wrote in Gravity's Rainbow, if they can get you asking the wrong questions, they don't have to worry about answers. So I asked, do you want health or health care? This is the Health USA, published by the CDC, and it just presents again the same thing. In 1960, the second most column on the right says that we were 12th in the infant mortality rankings in 1960, but by 2004, according to their limited number of countries, we were 29th. And I would suggest that our goal in this country should be to get back where we were in 1960, and I think we can do it. But it's going to take a while, and it's going to take a lot of effort. And to help us, this PBS series is airing starting March 27th for 4 consecutive Thursdays for an hour. Is the program called Unnatural Causes. Is Inequality Making Us Sick? And you can see how health is reflected. And the reflection says, wealth. Maybe you can't see that. So if you go to the website, unnaturalcauses.org, you can find information. You can also get a community action toolkit. And from Unnatural Causes, you can get segments to screen in your community and things to do to create awareness about this. So, to end, our health considered as individuals or as a country is not up to today's standards, which I offer would be somewhere around Japan and those countries. That early life, before we make any conscious choices, matters more for our health than any other period. And political choices governing the use of societal resources for supporting early life and decreasing the hierarchy are necessary to get us healthy again. So as we go down to the income gap store and check out the new tax cut fashions for the fall, I ask you to ponder on this, and that this is the kind of surgical procedures that we're going to need. Thank you.
Our next speaker, Dr. Benjamin Danielson, is a medical director at Odessa Brown Children's Clinic, a community clinic of Children's Hospital and Regional Medical Center. He's a clinical associate professor in the School of Medicine, Division of General Pediatrics. Again, a Harvard graduate with medical degree from the University of Washington and pediatric residency at Children's Hospital here. He works to increase diversity within the pediatric residency program by serving on the UW School of Medicine Office of Multicultural Affairs, Diversity Board, the African American Mentor Network, and as a mentor through the Multicultural Affairs Office Summer Medical Education Program. In recognition of his work, he's the first holder of the Janet and Jim Senegal Endowed Chair for the Odessa Brown Children's Clinic in 2005. As you can see, he was awarded the Lauren Miller Bar Association's Community Service Award in 2007 and received the Charlie Garcia was the director of the Office of Multicultural Affairs up until a few years ago, Distinguished Faculty Award for Mentorship in 2004. So it's a pleasure to call Dr. Danielson to the podium, and he will give the second of the talks this evening.
Good evening. So I'm going to talk about a couple of points. I'm going to reaffirm what you've just heard, that health is really determined by much more than our healthcare system. I'm also going to point out that from what I see working in the front lines with families and kids every single day, that bad health is strongly influenced by 3 things: poverty, race, and our healthcare system. I hope it's okay to use the word racism tonight, because I get really tired of terms like disproportionate or health disparities or inequity, because the issue really is, when you talk about race, this is institutionalized racism that we've been supporting and growing and nurturing in a very quiet but sustained manner for many, many generations now. So what influences health? We have these societal influences, these behaviors, we have poverty, and then we have culture. And when you look at our healthcare system, does it do a good job? How does our healthcare system do as you measure it up? How do societal influences affect our healthcare system and our health? As you heard from Dr. Brzuczka, the measure of our healthcare system in this country is pretty poor. A Commonwealth report that was done just a year or two ago gave our healthcare system a report card, used 37 indicators. The U.S. healthcare system got a 66% in this scorecard, which is essentially a failing grade. And what it also found was that if you close the gaps across the scorecard, you could prevent 100,000 deaths easily and save $1 billion per year, $100 billion per year. Insuring the uninsured would save our economy $130 billion a year. And the important point is that sometimes you're forced to make a false choice when people make arguments about our healthcare system, that insuring and covering more people would cost us more money. And in study after study that looks at this from a societal standpoint, that's really not the case. You are not choosing to spend more in order to cover more. This is one example of that, is when you look at state by state, how much each state spends on Medicare for its population versus how healthy that population really is in terms of mortality rates, you find that the states that, it's a cluster, it's just a wild cluster essentially. Hawaii, which anybody would love to live in many ways, stays very, very healthy, even though they spend a very small amount on their Medicare enrollees. After that, these states are all mixed and mashed in there. Washington's somewhere down in the lower middle there. There's no relationship between the amount of money you spend on any individual in this country and their health status. When you look at how our healthcare system has done over the past several years, this is a study that was just released just a week ago. It looked at whether or not the healthcare system had made any improvements in this country in dealing with preventable deaths. Preventable deaths are really considered the kinds of deaths that should have been prevented if our healthcare system were working effectively. Healthcare, this is deaths amenable to a healthcare system that works appropriately. And it finds that the U.S. is basically down in position number 14 for that. Again, reflecting a statement you heard earlier, 20 years ago we were actually only at number 6 or 7, so we've actually slipped further and further down the trail relative to every other country that's developed. And living in the U.S. is really actually bad for your health. Let's get back to that issue of infant mortality. And I really like that as a measure of the quality of a healthcare system, because it really does say a lot about a mom, her pregnancy, and those first few hours or days of life for a precious young infant. When you look at infant mortality rates and you compare them across different cultures, if you look at the second column, African Americans versus Africans, as an infant, you're better off being born in Africa. And as you look at every single column along that pathway, from Chinese is the next one, Japanese, Filipino, Mexican, Puerto Rican, Cuban, you're better off being born in those countries from an infant mortality rate standpoint than you are in this country. When you look at our country as a whole and you look at our obesity rates, I'm sorry that's a little fuzzy, but you can see pretty easily that the most rotund shape there, of course, is the USA. We've all seen those data before. And that we are far, far outstretching any other country in terms of obesity issues. And the ramifications, the healthcare ramifications of that are pretty significant. Even if you come from another country and acculturate to our country, then your obesity risks, your risk for diabetes, your risk for mortality and morbidity approach our country's risks very quickly. So not just being born here versus being born there, but moving here also increases your risk for poor health. So what influences health? We've talked a little bit about societal issues and things like that. Behaviors play a small, small role when you measure them across populations in health outcomes. As you've seen earlier in Stephen's discussion, poverty and race, culture, ethnicity are extremely important factors. And I really want to spend a little bit of time separating those two issues out with you, because the easy fallback is to always say that the issues of race and ethnicity in this country are basically the issues of poverty. They're not always that clearly cut. So let's look at one issue, just looking at poverty specifically. I'm going to show you a couple of maps of a satellite's eye view of this country, and I want to just overlay a couple of concepts for you. First is just a topography of poverty in the U.S. that was done by someone named J.B. Holt just last year. And it really looks at county by county the poverty rates. And as you get darker in color, you see greater relative amounts of poverty, and you see where the concentrations are of poverty down in the southeast. Let's look at how they broke that down a little bit more. And as they went area by area, they really started to demarcate what they called a continental poverty divide that separates this country economically and really affects the southeast part of this country in a way that the rest of this country does not understand or experience at all. Now let's think about state-by-state health. And this is just a set of data that was sent by the Commonwealth Fund and in partnership with an approach to try to identify the healthiest state in the country. Washington State ranks, I think, number 11 or 14 right now. And as you get darker and darker, you see poorer and poorer health by the 11 different measures that this study was doing to look at how healthy each state is. And as you can see, essentially, as poverty increases, you can overlap that almost directly onto how healthy each state is. It is interesting to see that California and Nevada also have poor health records, and one of the big issues there is actually migration of immigrant populations and the health care that does not get served to undocumented populations as they move into those states. Poverty influences death rates specifically, and this is another study that just came out in January that was looking at 2001 data for death rates, and it really identified that there were 215,000 excess deaths in this country due to education disparity. And I will put to you that education equals economic empowerment in this country, period. Economics and education are tightly aligned. And in this study, they used an algorithm to say that 215,000 excess deaths occur in this country due to education disparity. 48% of deaths in males and 38% of the deaths in females were due to this education disparity. You can even measure specific parts of a body's function and look at poverty and how that affects that. If you are poor, your lung function decreases by 300 milliliters if you're a male and 200 milliliters if you're a female. Specific correlations between how your body works and how your pocketbook works. Poverty in this country has a disproportionate effect on your health when you compare it to any other country. This is a recent study that was done last fall, and it was comparing the 5 quintiles of economic level in the US and in Canada and looked at different elements of health. And it basically found that in the top quintiles, the health status was very, very similar across the economic lines. It was very, very similar for the top 3 quintiles. When you got down to the bottom 5th quintile, the poorest populations, Canada was able to sustain healthier health rates than the US was. You're healthier if you're poor in Canada than you are if you're poor in the US. And this issue of education and poverty and fitness and health are really linked pretty directly even in childhood. You don't have to sort of wait for your education not to work for you. You don't have to wait to be poor because of a poor education for it to affect your health. This is just an example of that. This is just a study of the president's physical fitness testing scores for kids who are in school in the 4th and 5th grades in Kaiser in California. And it looked at how well they did on reading, language, and math scores, and really, again, found that the link between education and fitness and health is really tight, and it's tight right away in childhood. It's a direct connection from childhood on. This is really important because our health and our education system seem to be doing such a poor job of understanding what really influences success. We give up our physical education and our physical health in our education system, thinking that we need to sacrifice it to make us smarter. And in fact, we actually sacrifice our education at the same time. Now, I want to talk about race, because race really matters in this country. Race is not a comfortable thing to talk about, but it matters when you're thinking about healthcare. And I see that it matters every single day in my work. If you just looked at basic issues like mortality rates, even in this state, you would see that race matters. If you look at different racial categories in this state, you'll find mortality rates are different. If you look at the different causes of death in this country, you would see that for each race or ethnicity, the causes of death are very different. They're ranked in different order. If you look at basic elements of health, this is for SIDS, sudden infant death syndrome, something that we pat ourselves on the back for making such an important difference in. You'll see differences based on race. We pat ourselves on the back for making improvements that are really experienced by a Caucasian population in this country, while Native American and African American populations experience the SIDS rates that the Caucasian population saw 25 years ago. If you look at other issues, like whether or not your very low birth rate at birth, being very low birth weight just by itself is a significant indicator of how unhealthy a child is going to be throughout the rest of their life. And as you look at race, you see differences. If you look at any other measure of health, neonatal mortality, the infant mortality that we keep talking about is 2.5 times higher for African Americans than it is for the general population. Prematurity, premature births happen more often. All life-limiting chronic diseases occur more often and are more intense for minorities in this state and in this country. Conditions like autism, behavioral conditions, issues like just the basic plumbing of your heart, whether or not you get a heart surgery on time if you're a baby with a hole in your heart, is different based on the color of your skin. If you look at cancer rates in this country and in this state, breast cancer rates for African American women are at the rates that they were for Caucasian women 25 or 30 years ago. Look at leukemia, the most common cancer in childhood. The leukemia survival rates, 5-year survival rates, which is how we measure cancer survival. If you look at the difference between Caucasian, African American, Native American, Hispanic, Latinos, those lower survival rates for those minorities are the rates that Caucasians saw 25 years ago. You pull this data together. This is a wealth of data. There are hundreds and hundreds of studies that show this over and over again. And the Institute of Medicine between 1999 and 2002 decided to sort of look at all of this data. And what they did was they held constant issues of insurance and income, severity of diseases, patient preferences, sort of behaviors, the appropriateness of the procedures, age or gender, held all of those constant, erased those as factors in the healthcare delivery. And they still found that there was a consistency in these findings, that minorities are less likely than whites to receive needed services, including clinically necessary services and procedures. And these disparities occurred in clinical services that are equally effective, that would have been equally effective for everybody. Race, poverty, interact when I work with families. I can't just say that your race is affecting your health in this particular way and poverty is affecting your health in this other way. Race and poverty are intertwined and interact to influence a child's health in the families that I work with, to influence everyone else's health too. And it's always a little bit, it's embarrassing sometimes for me, to be honest with you, to talk in this setting, pontificate about the issues, talk about bars and graphs, sort of talk about high theories about whether it's your health or your health care. To the families that I work with in the clinic, it doesn't matter. They're sick. They're having healthcare issues. They need services, and the quality of those services is not up to the standards that we would expect. This is a fun discussion, but we're talking about real people's lives. And in this recent study, when you looked across 12 different kinds of common forms of cancer, prostate cancer, colon cancer, and things like that, if you're uninsured or on Medicaid, your cancer is diagnosed later, 2 to 3 times more likely to be diagnosed later. If you're black, for 10 of those 12 cancers, you have a higher risk for being diagnosed later, even if you have private insurance. Poverty and race interact to affect health outcomes. If you look at maternal and infant dynamics, this is King County. This is the central area. These are the families that I work with every day. And this is reducing things to numbers. But these are real people that I work with every day. And the families that I see, the issues they deal with, they are broad and deep, and they affect every social aspect of their lives. So when the child is born, its low birth weight is going to happen 2 times more frequently than other families. The families I see, preterm happens 1.5 times more often. Teen pregnancy rates happen 2, 3, 4 times more often. Being a single mom, being a parent or a kindred parent, like a grandparent raising a child, happens 3 or 4 times more often in our clinic. Getting late prenatal care, having a smoking mom, all of these issues are social issues that these families deal with that directly affect their child's health. And that means infant mortality changes. And you can look at how infant mortality changes in King County by different measures, and you can see differences. As poverty increases in this King County, infant mortality increases. As you move from one area of King County, say from Central to South King County, or from North or East King County to South King County, infant mortality goes up. The issues that these families deal with are myriad and deep, and they go from the full spectrum of issues that are just minor things but eat away every single day at their resilience, their ability to overcome challenges. So moving frequently, arguments, bills that they can't pay, death of a family member, having family parents who are separated, substance abuse problem, unwanted pregnancies, job loss, jail, fighting, homelessness. Homelessness for the families that I serve, 11 times more common than in the population in general. Those erosions in resilience are the direct factors that influence the stresses, the stressors on the bodies that you heard about a little bit earlier. The other issues that are just so hard to measure in any one particular way but have such an important effect on life, just those little things like, if I needed $50, could I get it? Could I call somebody if I was sick? Could I get a ride to the hospital if I needed it? Could I just talk to somebody when I needed to? Families from low income and from minority populations have those issues weighing on them much more frequently than other families do. And these are the things that affect health. These are the things right here. These are the things that contribute to those numbers, those bars and those graphs that we saw earlier. And I want to point out here just how poverty and race are sometimes different issues to look at. If we look at this study, which looked at how well educated a mother is and her race, and then looked at the infant mortality for her child. If you looked over here at the far left, you would see for a mom who had a less than high school education, those are the infant mortality rates for her child based on their race. And as you moved across to your right, you would see the changing infant mortality rate as that mom got a higher and higher education, and presumably as her level of socioeconomic status increased significantly too. And what is nice to see is that reducing poverty reduces infant mortality, and that's a very, very clear thing. It's very obvious, and you can tell that. But the other striking and sad thing to me is that if you're African American and a mom and college educated, the infant mortality for your child is still higher than for any other ethnicity at any other educational level. So we have to ask bottom line questions when we think about these issues, because all of these statistics are wonderful and great. All of these graphs are pretty compelling, I think. Most of this information is not all that new to most of you here, but you have to end up asking this question that my dad, the public health hippie in Boston, was pushing me to ask 25 or 30 years ago. Healthcare, is it a right or is it a privilege? We absolutely have to ask that question, and we have to answer it as a people. We can't keep just thinking about these numbers, putting up these graphs, having these fun conversations, and then sending me back to my community to work with these families and see the same thing happening for them. Is it a right or is it a privilege? So here is my little dream list of what I think we should do to try to make a difference. And I think it's been a little while since we've had a constitutional amendment. I can't remember when was the last time, but maybe it's time for us to think about a constitutional amendment. And a constitutional amendment that would guarantee quality education and quality health care for everybody in this country. Because once you answer that question and once you move to that, then the rest of this is just falling pieces into place. This is not a difficult issue to resolve. No matter how much people want to make it seem difficult, it is not a difficult issue to resolve. If we all agreed that health care was a right, then we could move forward. And I want to recognize that I do not say equality in healthcare, and I don't say equality in education, because I absolutely don't want my healthcare to be the same as yours, honestly, because I'm very different than you. Equality is a false issue and a false argument too. Equality is not what you want. You want quality. You want quality that reflects individuality and honors each person. We need universal access. We need a preventive focus that really flips our pyramid of spending in healthcare on its head and spends more money on prevention than on late intervention. We need early investments. And this issue of preconception, the health of a mom before she's even pregnant, these issues of early investments in the first 3 years of life, these are the places where investments pay off. There's actually a Nobel Prize-winning economist who put this out very, very clearly. He didn't care about the bleeding heart issues like I'm trying to convey to you now. He just wanted to know the numbers, what kinds of investments work well in different populations. And he ran the numbers, and he looked at what kinds of investment work well at different ages, and he found if you invest in somebody in their first 5 years of life, that investment pays off societally many-fold over, 8-fold over. What we do normally now is wait till somebody's really broken and either late teens or young adulthood, and then we invest in them. And his argument was you would be better off writing that person a check rather than creating a social program to support them. We need the removal of silos. One of the biggest frustrations for me in healthcare is that people don't seem to understand that my efforts in healthcare are directly related to a teacher's efforts in a classroom. My work as a pediatrician are directly related to a mental health therapist's work in the community. These issues of siloing professions and thinking about things within our own little constructs and with our own little blinders on are one of the major problems in our healthcare system today. And we need quality care that's based on evidence, and I mean good evidence, not just numbers that feel right to us. We need a rigorous monitoring of our health outcomes and an environment of humility and appreciation for differences. And when you talk about issues of working with people across different socioeconomic strata or different races or cultures or ethnicities, and you ask them what they want from healthcare, they don't want any special magic bullet. They don't want you to necessarily know when you're supposed to shake their hands and when they're not. They don't want you to understand the minutiae of their culture. They want you to approach them with honor and humility and appreciation for someone who is different than you. Thank you very much.